Good evening, everyone, and welcome to another very interesting Asian anesthesia patient safety rounds. Today, we have quite a few important aspects that are going to be covered by our very enthusiastic speakers today. So, first up, we'll have Dr. Viral Parekh, who is a consultant anesthesiology at PD Hinduja Hospital and Medical Research Center in Khar, Mumbai, followed by a presentation by Dr. Bhavya Krishna, who is an associate professor at VMMC and Safdarjung Hospital in New Delhi. I welcome these two speakers, and we're very happy for them to be so very actively involved in sharing all these experiences from our, the newsletter of the Anesthesia Patient Safety Forum. So with that, I'll hand over the stage to Dr. Viral. Viral, you can please start your presentation.
So, thank you, Dr. Archana. So first I'll start sharing my screen. It's visible, right?
Yes, it's okay.
One second. Yeah. So a very good evening to all. At the outset, I would like to thank the APSA India, Dr. Bala Venkat sir, Dr. Murli sir, and Dr. Sunil Pandya sir for giving me this opportunity to invite me and giving me this opportunity to present on this platform. So today's AIR sixth round, I'll be yeah, uh, presenting on two of the uh, critical incident reports which have been published in the last newsletter. So I have no conflict of interest, and the incident reports were published in the AI report of the May volume. So the topic which I chose is a very practical aspect, the unseen block, a critical reminder for equipment checks. So it states that at the start of the day, the anesthetist, it was the first case, and the patient was a middle-aged man, posted for laparoscopic umbilical hernia repair. After the routine call out and attachment of standard monitors, the patient was induced and a firm mask seal was confirmed. However, there was no capnography trace, and despite repeated attempts and well-fitted mask, the reservoir bag remained motionless. A quick check revealed that the cap on the catheter mount had not been removed, silently preventing effective ventilation. So this is how it happened. As it was said that it was the first day of the case, a middle-aged male with for laparoscopic umbilical hernia repair. The routine standard monitors were applied. The checklist was done. And the patient was induced with fentanyl and propofol. However, there was no bag movement, and on the monitor, the ETCO2 trace didn't appear. So, with initial confusion by the anesthetist, then he just came to a conclusion that I'm not able to ventilate. So he came to a point-wise system like what could go wrong. So the possible causes which were considered were the poor mask seal, airway obstruction, laryngospasm, circuit disconnection, or equipment malfunction. And after thorough checking, it was seen that the airway was fine, the machine and equipment was okay, but there was a block in the circuit because of the cap at the catheter mount. So after removing the cap, the patient was being able to ventilate it and the ETCO2 graph came in. So this was a case of a near miss due to an obstructed breathing circuit. And it taught us that every near miss is a lesson which is waiting to be learned. So in the same article, another case which was reported was the anesthesia for a minor surgical procedure in a child. What happened is following induction, there was obstruction, complete airway obstruction, and it occurred because of a cap from the intravenous administration set, which became lodged within the angle piece of this connecting the circuit and the filter to the face masks. And the cap was translucent, so it was not readily visible within the colored plastic angle piece, which resulted into hypoxemia and it led to the death of that kid. So such critical incidents keep happening, and we need to be having utmost vigilance. So coming to the root cause analysis of this case, the nature of error was a failure to remove the protective cap from the catheter mount before use. And on multiple factors contributed to it. So the human factors, it was an assumption by the anesthesiologist that the circuit has been checked or inattention. The equipment factors, there was a protective cap and it was a hidden obstruction which was not seen clearly. The environment factors were like it was the start of the OT list, so all of us usually are in a hurry in the beginning because there is a lot of time pressure, the surgeons are waiting. And the system factors, there was incomplete equipment check and there was a lack of structured checklist, which led to a ultimately outcome in such a way that the anesthesiologist was not able to ventilate. So this, what happened was similar to the Swiss cheese model. The negative aspects came into a straight line, and because of the obstructed breathing circuit, there was difficulty in ventilation of the patient. Had it not been diagnosed appropriately, so what could have gone wrong? The patient might have had a rapid oxygen desaturation. It could have led to hypoxic brain injury or cardiac arrest and emergency airway intervention, which can lead to significant patient comorbidity. So multiple case reports have been published in the literature. So this was from our own Indian Journal of Anesthesia by Professor Sheila Maitra Madam and Raghu Sir. So in that case, similar incident had happened. So after induction, again, the catheter mount had a red cap which was not removed by the junior anesthetist, and the drugs were given and they were trying to ventilate the patient. So initially they were not able to ventilate, so they just put the patient on a ambu bag and then the chest rise was adequately seen. And on further examination of the circuit and the machine, they came to this conclusion. Similarly, there are other studies in the literature. This is about the critical incidents and near misses during anesthesia. So this was a prospective audit which was published in 2017. And what they mentioned was the phase of the occurrence of critical incident. So in most of the cases, the induction is a very high risk situation because all of us want to start our case early and we might miss certain things. And majority of the critical incidents happened in that phase. And multiple factors, as I mentioned, the patient factor was the most common in this scenario, around 38%. But other factors were like human error, equipment errors, and the surgical factors. So what they concluded that the critical incident reporting should be introduced and encouraged in all anesthesia departments in a blame-free culture. You should not try to blame each other, just retrospectively try to analyze and come to a conclusion that this had gone wrong. So how we can try to prevent in future. Similarly, this was another interesting case which I came across. It was the anesthetic breathing circuit obstruction, which mimicking severe bronchospasms. So again, this was a pediatric patient for a hernia repair. Post-induction, there was difficulty in the bag mask ventilation. Airway was inserted, still there was difficulty in ventilation. There was a suspicion of laryngospasm, so succinylcholine was given. The child was intubated. In spite of the tube being in place, there were a high peak airway pressures with low EtCO2 trace. And further, it was a suspicion of bronchospasm. So inhaled bronchodilators and steroids were given. So in this scenario, what happened is that the anesthesia machine ventilator also failed simultaneously. So luckily for the patient was shifted on the open circuit when there was a dramatic increase in ventilation. The adventitious sounds were absent. There was adequate chest rise. So when the anesthesia machine and circuit was rechecked, so as you can see on the left side of the tubing, there was a thin plastic film inside the tubing, the circuit, which was causing the obstruction and mimicking similar to bronchospasm. So the machine and the circuit were changed and the case happened uneventfully. So other than obstruction, we regularly face multiple cases in which we have circuit leakages at multiple levels. So this was a case report which was published. So here what happened, the breathing circuit was placed in the tube holder, but the size of the tube holder was not appropriate, similar to the size of the circuit. And due to incorrect angulation of the placement of the tubing, there was a rent which led to unexpected leak, which was identified and further action was taken and the surgery went uneventful. So this is one case which I have myself had. So this was like a young patient for a gynec surgery. Patient was induced and patient was given position. mid-surgery, I could notice there was some leak in the anesthesia, in the expired tidal volume, so around 150 to 200 ml. So we started the machine check with vaporizers, the breathing circuit, and we checked everything. Then I went to the patient end, and as you all can see that there is a small rent which had happened in this endotracheal tube. So at this point, I was in confusion whether I should remove the tube or what should I do, because the surgery was about to finish in next 15 to 20 minutes. So and it was a minor leak. So what I did was just I put some Dynaplast sticking and the leak subsequently got resolved and there was no further implications. So continuous vigilance is very much important. Similar to my case, I came across this case report. So again, in this case scenario, what happened was there was an unusual site of leak in anesthesia circuit. So there was a large point of entry of inflation line of pilot balloon. As you all can see, the point from which the pilot balloon connection comes. So the entry point was large, which was causing the leak. And again, it was diagnosed and subsequent action was taken. So multiple case reports have been published in the literature. This was another article which had come in Indian Journal. So here there was a defective HME filter. So again, after induction, the patient was tried to mask ventilate, but it was difficult, and they again suspected bronchospasm. So, however, since the patient was given a muscle relaxant, the patient was intubated, and a non-rebreathing ambu bag was connected, which showed that adequate chest rise, and again, the HME filter was the culprit in this scenario. So our own Indian Journal of Anesthesia suggests a anesthesia machine checklist. So we should follow it daily. They mention that a self-inflating bag appropriate for patients' age and alternate O2 source should be available. Pipelines, power source, cylinders, all needs to be checked. The machine leak check should be performed daily. And again, if there was no vaporizer and if you have connected the vaporizer, then you need to perform it again. The breathing system leak should be checked, functioning of one-way valves and sufficient CO2 absorbent, whether it's present or not, should be checked. The ventilator function. So all this equipment test needs to be done daily. And a beautiful quote which I came across, that the equipment doesn't fail patients, but the unchecked equipment does. So it's our duty to do it regularly. And the key learning points were: never skip the anesthesia machine check, verify circuit patency. The first case of the day is a high risk period. Observe the basics and report near misses. Because the role of critical incident reporting is to identify the latent system failures, promote a culture of safety and transparency, enable root cause analysis, drive institutional protocol changes, and prevent recurrence. A near miss which is not reported is uh, the next accident, and thereby request all of you to report all your critical incidents in docked app. So again, as it has been mentioned previously, there are no patient identifiers, there is no reporter information which has been collected. It is the data gets auto deleted after 7 days, there is no storage. So the anonymity will be retained and your identity will not be revealed. So thank you so much, and patient safety should be our priority.
Thank you so much, Dr. Viral, for that very lucid presentation. Okay, we'll now open the house to discussion. I'd like to invite Dr. Anju Ma'am, Dr. Anju Garewal, who's a very senior professor with a lot of experience, I'm sure, in this aspect. And we also have quite a number of experienced people here to share their experiences with us. Ma'am, would you like to share or add anything in your experience regarding this topic that we've discussed today?
Yeah, thank you so much, Archana. Actually, am I audible to you all?
Yes, ma'am, you're very audible.
An excellent presentation, Viral. I would say that this indeed, as you said, the first case is the pressure time zone, but also equally as important is the last cases, and we are in a hurry to finish off our list, right? And what we recently encountered was something the opposite, that we had this entire, circuit up there, and when you have an ENT surgery, it's all under the drapes. And therefore, the catheter mount, there is a small knob that actually comes off, which you use for suction. And it kind of got open underneath the drapes. And Then, there was a loss of ventilation, and then as is very, very pertinent, I believe, though we use dopes as a kind of a mnemonic for transport of patients, but I think the first thing that should come into our mind is, of course, any malfunction happening in our system, in our equipment. But extremely important is the fact that not only is the machine check important, but also checking your circuits is equally important. In our times, I remember when we had those old boiled machines, somebody would come in between, even after the check was done, and insert a vaporizer, and then it would be, loosely attached, and there would be a leak, and you wouldn't be able to ventilate. So all of these are very pertinent things, and most important is the fact that we rely too much on our technical staff to do these things for us. I think it is time that we do it. It just takes you maybe another 5 more minutes, but it is worth saving a life. So thank you so much for bringing this to the fore, and this really needs to be emphasized a lot.
Thank you so much, ma'am. That actually highlights a very important thing. It doesn't matter even if someone has done it before. I think it's important that whoever is administering at the head end has to be the person to do it again. And you're not losing anything by repeating the check anyways also. We also have Dr. Sapna Butler here today with us. Hello, ma'am. Welcome. Would you like to share or add anything to our discussion today?
Yeah, thank you so much. I just wish to already, Dr. Anju has already said about this, the importance, and Viral, it was a wonderful presentation. I congratulate you. It's a small
Thank you,
thing,
madam.
but yes, need to be discussed again and again. One thing I want to highlight is the importance of the communication. And the one that he said, assumption. Assumption is, I just want to highlight in a line that, as ma'am said, we just leave it on the technical staff. And in the medical colleges, generally it is the work of the postgraduates first year. And they are about to, do all the checks. And being senior, everybody says this is not my responsibility. I presume. So all the assumption is that we assume that the PG1 has done. Maybe sometimes he's not able to communicate. Sometimes he's not able to, check. So it is very important to do the cross check one and to remove the assumption factor, because having some critical incident and the causes assumption is very, very bad. It's very serious to need to look into. So one is assumptions, the other is communication. You keep the communication open amongst your team, so that one should not be, everybody should be on the same page. All the equipment paraphernalia has to be checked and communicated to the entire team. So if anything is lapsed, to be brought up right then and there only. So the two important things is assumption and communication need to be taken care besides all the technical stuff. That is very important. So my suggestion to the residents, to the postgraduates, and to the faculty as well, that please do remove these two errors whenever you work. Thank you.
Perfect message, ma'am. Thank you so much. Is there anyone else that would like to add anything? Yes, Yogesh, I know HME filters cause quite a bit of problems. Actually, even I've had a situation where we've had a cervical spine and we're in prone and we're in between the surgery and now it's blocked. Actually, it wasn't even a defect. It was just that it got blocked with secretions. And even at that time, we had quite a challenge in managing the ventilation aspect of it. But which we realized only after the surgery when we turned him and, we could remove it and see that it was actually wet. So yeah, that's a very big problem. Sometimes you should check the HME. I think actually now post-COVID, we're using more and more of the HME filters, and sometimes our technicians are very over-enthusiastic. They add 2 HME filters at either. So very key messages to be taken home today from this message. Thank you so much, Viral, to bringing this to highlight, and thank you, ma'ams, for your valuable feedback. So if there's nothing else from anyone, I think, yeah. So we'll go on to our next topic and our next speaker. We have Dr. Bhavya, who's going to present something also of equal importance. Dr. Bhavya, over to you.
Thank you so much. I will just start sharing my screen. Please tell me once you're able to see it. Is my screen visible?
Yes, it's visible, Dr. Bhavya. Please go ahead.
A very good evening to everybody. I would like to thank APSA for this opportunity and for really encouraging these very important critical incident discussions that we're having. These are all very minor incidents which happen, but you never know in anesthesia. Like they say, there's hours of boredom, minutes of excitement, and seconds of frightenment. So this is just to avoid those what we consider to be small things, to avoid big mishaps from happening. Today I'll be discussing silent disconnects, the incident that was reported in the newsletter. I'm just going to read it out. Silent disconnects, unplanned extubation, and misconnection in anesthesia. Viral has already helped me by pointing out quite a few things and quite a few checklists. The case goes as during an elective tonsillectomy, the ventilator began alarming for low tidal volumes and leak, with reduced chest rise and a falling end tidal CO2. Closer inspection revealed that upward pressure during throat pack insertion had partially dislodged the endotracheal tube, with the tip now lying high in the oropharynx and an audible leak around the cuff. The throat pack was promptly removed, the tube was repositioned under direct laryngoscopy to an appropriate depth, and cuff pressure and fixation were reassessed. Ventilation parameters and gas exchange normalized, and the surgery proceeded uneventfully. So, just summarizing what we heard, it was an elective tonsillectomy and there was a sudden deterioration before the surgery had even started. So, patient is undergoing the surgery. We are assuming that the endotracheal tube is secure. Ventilation is stable. Now, during a throat pack insertion, there are several things that got highlighted to us. One was a low tidal volume alarm, which we're assuming are, whether it was a resident or a practicing anesthesiologist, was activated about such a thing, was able to see the alarm. An audible air leak was detected and the EtCO2 began to fall. What is very important is that EtCO2 was available. In most medical colleges, in most tertiary care centers, capnograph is something which is available to all anesthesiologists. But we must remember there are centers where a capnograph is not available. So this case is just highlighting how important a falling capnograph is and what story it tells us. So when a ventilated patient suddenly develops a falling end tidal CO2, a low tidal volume, or a leak, if you don't have an alarm activated, he was able to hear an air leak and reduce chest rise. What must we think? Is it the patient? Is it the airway? Is it the circuit? Or is it us? So when suddenly an EtCO2 drops, it could be an unplanned extubation or it could be a misconnection. And we must remember that a falling EtCO2 often precedes a desaturation. And hence we must trust capnography early and not last. There are studies which show that capnograph shows us that there is a problem in ventilation at as early as 30 seconds, whereas a desaturation can take up to 4 minutes to show up in our monitors. So what is an unplanned extubation? It is where a removal or displacement of the endotracheal tube is before it is intended. If we're talking about the intensive care units, it can be a self-extubation where a patient deliberately removes the tube. It is common, if the patient is under light sedation, especially at night where our staffing is lesser. There can be an accidental extubation caused by staff manipulation during care or non-purposeful patient action. There could be a device malfunction or internal dislodgement. Risk factors could be there in the patient as well as in the system. In the patient, if we're talking about general anesthesia, most common cause is when there is a shared airway. In the ICU, what has been shown is in the male sex, in delirium or in light sedation, it is more common, or wherever there is a difficult tube securement, for example, facial swelling or burns, or there's been a history of previous unplanned extubation. In the staff and system factors, in general anesthesia is where there's a shared airway surgery, prone position, or in fact any position change and transport. Other factors in our critical care centers could be junior or less experienced staff, where there's low nurse to patient ratio, inadequate tube securement or checks, absence of a clear extubation protocol, or when the restraint use and sedation choice is not adequate. In this particular case, how could a throat pack insertion have led to this unplanned extubation? What happens is when the throat pack is inserted in the oropharynx, there is a Kefauver pressure on the endotracheal tube, which pushes the endotracheal tube proximally, and the cuff passes upwards from the cords and causes a partial extubation. It is an under-recognized and costly burden, especially in the intensive care unit. It is shown in up to 80% of neonates. 1 in 5,500 general anesthetics had a serious airway complication due to an unintended extubation intraoperatively. And talking about the cost, since there are no Indian data available on the costing, the costs in the ICU is almost $5 billion. So a single unplanned extubation can cause a variety of problems. So how can we recognize this failure? When there is a falling EtCO2 or when there is a doubt that the tube could have been dislodged, we have to go through a DOPES checklist. The D stands for displacement, where the tube could have migrated above the cords or intrabronchially. We should think of obstruction, where the obstruction could be inside the airway tube due to secretions, kinking, biting of the tube or of the equipment, the breathing circuit. A pneumothorax due to a sudden barotrauma, especially after positioning. Equipment failure, which could also be similar to cuff disruption, which is again something common when we're doing sort of some mental intubations or throat pack insertions, circuit disconnection, misconnections or ventilator fault, or stacked breaths, where there's breath stacking, dynamic hyperinflation, or gastric insufflation. The other silent disconnect is a misconnection, where a breathing circuit gets disconnected, and it has been recognized as a leading anesthesia critical incident since the earliest equipment studies. In fact, even in 1984, breathing circuit disconnection was ranked as the most frequently reported critical incident. In about 80,000 general anesthetics reported in Australian incident monitoring, leakage or misconnection of the breathing system was the most common equipment problem, out of which 25% was because of human error. And in most of these cases, a change in the capnogram was the first monitoring which flagged this disconnect. So there's a structured cognitive algorithm available called Cover ABCD, a Swift check. Now, this is something which can be used as a first response in anesthesia and critical care for almost all the emergencies that we come across, and it has been validated against almost 2,000 incident reports. The cover is a mnemonic, where C stands for where you check the color, circulation capnography, O for oxygen supply, oxygen reservoir and analyzer, V for ventilation and vaporizers, E for endotracheal tube, and eliminate the machine if in doubt. So in elimination of the machine, you go through the safety checklist of the machine that Dr. Viral just pointed out. In R, you review all the monitors and equipment. ABCD, like we all know, stands for airway, breathing, circulation, and drugs. And a Swift check is again another mnemonic, which if used correctly, it has been shown to correct the underlying problems in more than 60% of anesthesia crisis. So what is this, a Swift check? I'm just going to briefly show you the table. It is again a mnemonic which covers everything available in the operation theater. It works as a cognitive checklist and covers everything right from air embolism, anaphylaxis, air and pleura awareness, any surgeon-related problem. For example, there could be vagal stimulation, caval compression, etc., sepsis, wound, water intoxication, infarct, insufflation, fat embolism, full bladder, trauma, tourniquet, catheter problems, cement, hypothermia, hypoglycemia, embolus, endocrine, checking the patient, checking the case notes, checking the perioperative status, potassium, and keep. So if this cover ABC, a Swift check is used, we can cover all the emergencies that we cover in anesthesia with a good success rate. Now, let's assume we have such an unexplained extubation like we did in this particular case. How do we manage it? So attend to life threats first. We hand ventilate with 100% oxygen and return the patient to supine before troubleshooting the cause of the patient was not in supine position already. Manage the breathing and ventilation. Anticipate difficulty, where we check the prior airway grade, obtain the difficult airway trolley, call for help. If stridor is present, plan for a smaller ET tube. If it was a difficult airway, we plan accordingly. And document the event, enter it into apps like DOG, and enter it into a risk monitoring system so that the root cause can be addressed. Like Dr. Viral mentioned, we have to follow the Swiss cheese model of safety, ensure that we are crossing all our barriers to ensure that such a thing does not happen, and do a root cause analysis, like why did this happen, and do a systematic review. There could be patient factors like difficult anatomy, neck mobility, airway difficulty. There could be procedure factors like head end manipulation, throat pack insertion like we saw in our case, or equipment factors like improper endotracheal tube fixation, circuit security, alarm settings. Human factors like distraction, fatigue, communication gaps. A lot of times you see when you enter the OT, the alarms are off, but the residents are on their phones and they're unaware of what is happening. And of course, system factors like the use of checklists, which is a very core part of our specialty, but we tend to forget using those checklists. Supervision and escalation protocols. especially when there's a shared airway surgery, vigilance cannot lapse because there are a lot of opportunities for the tube to get migrated, especially during the cervical extension for surgical access, throat pack insertion, gag placement, surgeon manipulation, and compensatory cuff over inflation. The tube can migrate cephalad or distal almost 2 centimeters, is what has been shown in several studies. So, reconfirmation of tube position after every position or surgical field change should be done, and it should be a continuous monitoring. So there should be prevention bundles that we build for such patients. One should be before surgery, where the tube is secured reliably. The depth should be documented correctly during surgery. Again, you reconfirm the position after any movement of the head, after any placement of throat pack or gag, and there should be dedicated staff for suctioning, turning, and transport. Once again, at emergence, it should be done to confirm throat pack removal, and you recheck the depth before extubation. I want to highlight that this checking of the placement of the tube should be done continuously in surgeries where there is a high risk of anticipation of tube migration, or to prevent these unexpected um, extubations. Now, the role of simulation, like now, NMC has made simulation labs compulsory in all medical colleges. And there was a very interesting study done in 2022 where intraoperative accidental extubation during a thyroidectomy, which is a known difficult airway, was conducted. And the residents showed 94% improved confidence in identifying accidental intubation, 94% improved confidence in re-establishing a difficult airway intraoperatively, and 100% psychologically safe debrief environment was reported. So we need to come up with different sort of learning methods, learning teaching methods to help teach these education. Again, in NAP4, we learned some lessons on the causation, where airway events are rarely due to a single error, and recognition failures are common. So we must focus on recognizing these failures. Like already discussed earlier, highlighted by Dr. Sabna, that communication failures are also common, and most events involved experienced in daytime clinicians. So for the take-home messages that I would like to drive across is a falling ETCO2 often precedes desaturation. Trust the capnography, use it whenever available. Shared airway surgery is it's a recurring high-risk window, not a one-time check at induction. Misconnection is preventable by design, and engineering beats vigilance alone. Reach for a structured core algorithm, for example, the cover ABCD, before chasing a single diagnosis, and track every unplanned extubation and misconnection, because what isn't measured isn't fixed. So we need to report these incidents to have better algorithms in place. Thank you so much.
Thank you so very much, Bhavya. Very nice presentation and very nicely highlighted all the points. I mean, it took me back to, in a medical college, and every time I'm worried when the new PG is doing a tonsil, and it's not just during insertion, it happens when the gag is removed too. They extubate the case for us as well. So I'm like, dude, it's okay. I'll extubate my patient. Please take care of your side. We'll do our. But yeah, points duly noted. So okay, now that we have the floor to discussion. Anju ma'am, would you like to add anything with this? I'm sure you must be having several such experiences.
I think tonsil is indeed always a nightmare,
Yeah.
especially when you have a new batch of residents coming in and the older one going out. And always not only at the time of induction or when you're putting, and as very rightly pointed out by Bhavya, at all times, we really need to keep a real check on that, on our, the patency of the tube, whether the tube is inside. What is very, very important, I believe, here is what is that picked it up in time is that the alarms were not muted. More often than not, you see anybody coming in and why is this, going on? So they just keep and put it onto silence for another 2 minutes, and we do not know what happened during that period. And in today's times, I think one of the messages that should get across to everyone, whether you are working in a government medical college or a private setup or a small unit or a standalone unit, an end tidal carbon dioxide monitor is extremely important and pertinent. I think we shouldn't be, as anesthetists, we shouldn't be kind of trading off with that. I remember in one of my interviews when I appeared as for an assistant professor, I was asked that you only have money to buy either an end tidal or an SpO2 monitor. What would you buy? And obviously, the choice is always an end title because it gives you much far better and important information than an SpO2 saturation probe would give you. So that's extremely, extremely important. I believe what she has, Dr. Bhavya has taken us across a lot of points. But what is very pertinent is definitely we must have mnemonics, we must have everything. But in today's times where we are all so busy on our mobiles, vigilance is something that should not take a casualty. That is perhaps one of the key messages here, and very good that you pointed about doing simulations, because then sitting in one of the exams recently, one of the students pointed out, I haven't ever been there for a particular case, so I do not know how to give some kind of a procedure, or something was being asked and they kind of feigned ignorance. Maybe, sometimes you might be in a low volume center where you might not have encountered it, but perhaps simulation fills in the gap there for them. So that's extremely important. Your views, Dr. Sapna.
Yeah, thank you. Thank you, ma'am. Again, I think covered all the things, but of course, at this forum, I would be pressurizing more on non-technical skills also. So, because technically we have been taught the subject, we do follow all the algorithms. What I want to communicate here is one is safety culture. So, for that, we need to have a standardized protocols. This. So this has to be there in all the operation theaters, which everybody needs to look into, revise again and again, so that we do not deviate and bypass the SOPs. One. Number two, the culture of blame game should not be there, so that the more of the critical incidents come out, and from them we go towards no harm culture. So the more and more it will be, will pop out, we will discuss it, and we will take the corrective and preventive action if at all needed at our workplace. So there should not be any blame game culture. Safety culture should be promoted, and so that everybody should come out with what mishaps they had, they could manage, they could prevent, or they could handle. So once the culture is there in the institute, of course, more and more incidences will come out, and will be able to discuss it, manage it further better. So one is safety culture, one is having the standardized protocols across your institutes, and of course the best part is the simulation these days, which is very, very important, because as ma'am really rightly said, I have also gone for the examination of the students, and I found many students saying I have not got this case done. Now one is how to mark them for these cases, so that is okay, we change the case, but of course this is such an important case, and especially the shared airway where they do the proning. So the proning, etc., all the tips have been already been covered by Dr. Bhavya. So all the things that need to be taken care. So simulation takes a good care of all those cases which have not been dealt by many of the students. So I think that is the key points for these sessions. Thank you so much. Over to for the discussion.
Thank you so much, ma'am. Yes, ma'am, please.
Single point, and I just want to reiterate what Dr. Sapna has said, and the water flows from top down. So I think the best way to inculcate that safety culture is, as faculty, we need to take a lead and be there to show them by our actions. Children watch us more by what we are doing rather than from our slides. So I think that is where the real learning will and the shift will come into getting that kind of culture up there.
I think many of these studies are also going on at the international level, at the multicentric trials also, for the reporting of the critical incidents. So that is one very good thing. If you do not have any ethics issue, or even if you can take an ethics permission and you can contribute to that, and by the way, you can widen up your horizon and discuss your critical incidents as well. So that is a very good platform to discuss the things. That's also important.
Yes, ma'am. Thank you so much. Dr. Viral, would you like to add something?
Same, actually, what Dr. Bhavya has already highlighted. These two case reports, the main thing is the eternal vigilance. And
Yes.
as Anju madam really said, that the things percolate from top to down. So first we need to start inculcate, we need to do it ourselves. And that's how our juniors, the residents and the PGs will learn. And as I also mentioned, that for each and every case, the checklist has to be done. Means we cannot miss that, okay, this is an emergency. Still, you get to know about an emergency, you can spare at least 2 to 3 minutes, and that much is also sufficient if you are doing your checklist regularly. So, rest everything has been covered, I guess. Thank you.
Yes, thank you so much. And does anyone would like to add anything else? Anyone from the audience can unmute themselves also or put it in the chat box. So if not, I'll just begin to summarize. So we had two very important topics today, very seemingly small issues, but actually create a huge dent in management, during the case, after the case, make a huge impact in the outcomes. And the very important not to miss the small steps in the very beginning. Have your plans laid out, do it repeatedly. And as seniors, we should take a very big role in setting and leading by examples. So excellent points brought out by both of our speakers. Thank you, Dr. Bhavya. Thank you, Dr. Viral. And of course, our experts today, Dr. Anju and Dr. Sapna. Thank you so much for your valuable inputs. Thank you, our dear audience, for attending today. And I do encourage all of you to please use the DOCT app and do report all of your incidences. You remember, it is all anonymous, and we have Dr. Abdul Nazar with us all the time. He's available all the time to share and help you out with any difficulties you might be facing. So with that, I really do hope that you all will, join. And we have Dr. Murli sir joining back with us again. Murli sir, we'd like to thank you, Dr. Sunil Pandya sir, Dr. Bala sir, for starting this very beautiful initiative. And we hope to welcome you all again rounds another fortnight or so. So thank you so much, everyone, for attending today. I think with that, we can close the meeting unless anyone else has anything else to add.
I would just like to add like one small sentence.
Go ahead, Dr. Bhavya, please.
When we started anesthesia, I think on our first day, we were taught what is the ASA standard monitoring. That's the first question we're all asked. And what we remember from day one of all of us entering anesthesia is the first monitor is a trained anesthesiologist. So we must never forget that. It is very good that we have all sorts of monitors now, all sorts of alarms now. We have very fancy monitoring. But if an anesthesiologist is not vigilant to observe those monitors, it's of no use, which is, I think, the highlight of both Viral and my presentation today. So let's not forget, we are the most important monitors.
Perfect message. Perfect.
Yeah. Can I add something?
Bhavya's message
Dr.
with one
Shweta
more
here.
Just a second. Yes, Dr. Shweta, please go ahead.
Yeah. So basically, what I've realized is that what we have seen it in our residents also, that they identify now with all the so much of propaganda about identification of difficult mask ventilation, airway management. They identify, but they are inadequately prepared for the thing in spite of knowing. So the preparation and the planning, because they're not prepared in the head, if there is a failure, then what next? So even if we talk of plan A, plan B, it's just like, yeah, we'll do this, but they are not actually serious about it, that how actually it will be executed, whether the expertise is there, whether the proper sized equipment is there. So we are little lacking on that side, and that's where we have realized that we fail most of the time and lead to, missed events or critical incidents. Thank you. It was an excellent talk, both the speakers. Great.
Thank you so much, ma'am. Dr. Sapna, ma'am, you wanted to add something?
Yeah, just wanted to add with Dr. Bhavya's statement that yes, you should be very vigilant about the monitors. Of course, the manual monitoring, I must say, as an old timer, I will still insist that this should also be there. So when you have a few residents sitting at one case and, everybody is busy with their mobiles and all, so at least one should be made responsible for manual monitoring as well. You keep your sense organs active so that you can catch up the event quite well in time. So that is manual monitoring also should not be replaced by any kind of monitoring. So that is one also key message.
One more thing which I would like to tell is that, as all of us said, that we have advanced technologically in the monitors, equipments, everything. But for every case the importance of ambu bag in the theater. Means we have seen so many cases of obstructed breathing circuits, displaced tubes, everything. So ambu bag has to be handy. And sometimes what happens, the equipments fail and there is no ambu bag at that situation. So that is one thing which I would again like to highlight.
Point well taken, sir. Yes. All right. So that's a great points discussed today and lovely discussion. Thank you so much to everyone for attending today. I think if there's no other thing to add, shall we close the meeting, ma'ams? Yeah. Yeah.
Excuse me.
Yes, sir.
Excuse me. It's an excellent presentation by both the speakers, especially Bhavya,
Thank you, sir.
and she reminded of this eternal vigilance. And my advice is, earlier this problem, I'm 1 years old. I'm not practicing. I'm in US today, and I'm living here. And unfortunately, the invention of these mobiles, it has helped us like anything. Now we are going to have our webinars, everything because of our mobiles, and everything is handy. But there are some negative points also for having mobiles which are allowed in the war. I feel they should ban the mobiles inside the war. They should be kept aside, and only in emergencies it should be used. Otherwise, you should never use mobiles. And it's a definitely distraction for the junior residents who never bother about the patient. That's why I always insist. I used to insist, take out your mobile. Don't keep the mobiles outside. Just keep it in your pockets. That's what I was doing in a teaching institution when I was working as professor in anesthesia. Thank you, Bhavya. You have covered all the points actually, which I could recapitulate all the things when in the prone position, especially when laminectomies are going on, or earlier we used to do posterior fossa tumors in the prone position. And of those days, when prone, especially in neurosurgery and all, these disconnections and all very, very, very common. One should be very, very vigilant. The best monitor in the war is the anesthesiologist, not the equipment. That's what you said. Thank you very much.
Thank you, sir.
You are from Safdarjung?
Yes, sir. I'm presently working in Safdarjung
Yeah.
Hospital.
You worked outside anywhere in Australia or somewhere? No.
No, sir. I've never worked outside India.
But you have presented excellently, excellent.
Thank you so much.
Especially most of the times it happened when I worked in Saudi for 9 years. So it happened for me when tonsillectomies and children were going on. There were 2 occasions where the tube was dislodged by the ENT surgeon while packing or adjusting something. And immediately there was no capnograph. But the only thing is I could notice that there is some problem. Immediately I asked the surgeon to get aside and corrected it and put it inside. When there is sharing of airway, this is going to happen, especially in this ENT surgery, as well as in maxillofacial surgery also. And maxillofacial surgery, but it is secure, though we are doing a nasal intubation. Sometimes if there is in maxillofacial surgery, we have done some 10 cases in the SVS Medical College, the submental intubation also. We intubate the patient regularly, orotracheal, then the surgeon puts a hole in the submental region and again put in the proximal end of the tube and then connect it. That's submental intubation. So always one should be very, very careful when there is shared airway, neurosurgery, prone position, pediatric cases, all these things. It's a lesson for these juniors not to use the mobile and distract. And some juniors are studying there. After anesthetizing, they're studying. I feel after some time what they're going to do, because of this artificial intelligence. Everything depend on artificial intelligence and may go to sleep also. This should never happen. Thank you very much.
Thank you, sir.
Thank you so much for valuable input. So thank you very much. I think we've discussed, we've covered quite a bit of points and have a lot of take-home messages today.
Yeah.
I really do welcome and hope you all do attend for the next air rounds in the next